When we were in hostel in medical school, it was very common that most of the students used to tell, hey, come on, don't be a pain in the ass. Did we actually know at that time how it is to have a pain in the ass? Hello there, I'm Dr. Purnendu Roy, a surgeon in Genesis Hospital, and today we are going to talk about an area of our human body which we can't see. And not only that, we are also very reluctant to show it to somebody. So yes, you guessed it correct. Today we are going to talk about pathology in and around anal canal, and three diseases we are going to discuss, that is piles, fissure and fistula. I've noticed one thing, that the people actually have the problem is pain while passing stool, or they have a problem of saying that passing blood during passing stool. But none of these people are actually aware of the difference between piles, fissure and fistula. We will not allow that ignorance anymore. So if you really want to spread this knowledge around, then please subscribe to my channel and share it with all the people, so that now there can't be anybody else who do not understand the difference between piles, fissure and fistula. Let's first understand what is piles. In our anal canal, the blood supply, the veins, they come in three different areas of like columns, which is, we call it 5 o'clock position, 7 o'clock position and 11 o'clock position. If these veins become varicose, which means dilated, they form grape-like structures which are called piles, and depending upon how severe it is, piles are classified into 4 grades. Grade 1, when it is inside the anal sphincter. Grade 2, when it comes out and goes back on its own after passing stool. Grade 3, when it comes out, doesn't go back on its own but can be pushed inside. And grade 4, when it comes out and stays out and can never be pushed behind inside. So these are the different grades that we understood. What is the main feature? They will say suddenly they saw a gush of blood in the pan, a lot of bleeding, but there is no pain. Remember, piles has got no pain associated with it. One thing that we try to tell people, if there is a person who is passing blood with stool, it needs to be examined. And it's not just the external examination. There is a thing called proctoscopy. We ask the person to take laxative, clear the bowel, come early in the morning, and we put a steel tube of proctoscope into the anal canal, and with the help of a torch we see the visual thing inside, whether the grade of the piles or if there is any associated things like polyp or ulcer or a growth. If a person is above the age of 40-45 who is complaining about bleeding per rectum, other causes has to be ruled out, because there is also a condition called secondary piles, when there is a tumor or a cancer and causing an obstruction, and that causes piles outside. We may just operate or treat the piles and miss the cancer inside. So every person above the age of 40-45 who is complaining about bleeding per rectum during passing stool should have a sigmoidoscopy or colonoscopy to find out if there is any other source of polyp or an ulcer or an ulcerative colitis or any cancerous growth inside. Now we have diagnosed this. Once we have diagnosed early stages of piles, we can treat with laxative, sclerotherapy. We can inject into these veins, that is phenol or any other sclerosing agents that causes shrinkage of the pile mass. There is another thing is called banding. It's like a very small narrow rubber band kind of a thing. We can use a particular equipment to put a ligating band around the base of the piles, and it sloughs off, and the next treatment is hemorrhoidectomy if it is advanced third or fourth stage, because in that case these lumpy grape-like structures is tied, ligated and excised. This is Milligan-Morgan technique of removal of hemorrhoids. And another latest technology that has come up with, it's called stapled hemorrhoidectomy. There is a type of a gun that is used, staples, and a chunk of the tissue is taken out from inside. So the venous connections are lost and the whole mucosa is pulled inside. That's called stapled hemorrhoidectomy. So fissure is when a person develops constipation and the hard stool, if there is a thicker girth, tries to come out from the narrow anal sphincter, it causes a crack. It's like a crack in the anal canal opening, and then what happens, that area gets inflamed red and it hurts each time the stool rubs. And I always give an example of, like in winter, if you get a crack in the angle of the mouth, you know, like when we try to open our mouth trying to have a banana, then it hurts. So that's exactly what is fissure, and the person will experience severe pain, burning while passing stool, and this pain and burning persists sometimes even for hours after passing stools, and the person will also see streaks of blood along with the stool on the pad. Now what needs to be done about it? Sometimes examination becomes very difficult because even a rectal examination with a jelly or a cream is so painful that that itself is the diagnosis of acute fissure in ano. One should not try to do a proctoscopic examination to see if it is so painful. So what should be done if you have diagnosed fissure? Give a simple analogy. As I said, what happens when we try to have a symptomatic relief for a crack in the lip? We put some kind of a cream and a balm, and we try so that we don't have to open our mouth wide, probably take smaller bites of food. Now here also we have three-pronged treatment. Use some kind of a jelly, whether it could be a local anesthetic cream or nifedipine cream in the local area. It can be used with a nozzle, and the nozzle can be put inside so that the jelly can be squeezed inside at the time of going to sleep, and while passing stool next morning, the jelly acts as a local lubricant. There's another concept called seeds bath, the type of plastic tumbler kind of a things which we sometimes use for giving bath to babies. Now you put in warm water and put a little bit of betadine solution, and after passing stools, and maybe 2 to 3 times in a day, we tend to sit in the warm water that gives a local heat and gives a soothing feeling. And the third is a laxative. Any kind of a laxative that should be used so that the stool is not hard. Now these are conservative way to treat fissure, and if still none of these things help, what's the cause of pain? Because of the crack and the sphincter has gone into spasm. So what we do is, under general anesthesia, a very small surgery called lateral sphincterotomy. We just divide the sphincter there so that the spasm is relieved and the fissure heals on its own. So now we understood what exactly is fissure. The third is fistula, fistula in ano. Fistula in ano. Now this presents with a small boil-like thing around the anal canal. That kind of ripens and then suddenly bursts on its own. Pus discharge comes and then ultimately becomes like a indurated, like a thickened reddish area through which constantly from time to time pus discharge keeps continuing. How does it take place? What happens is, in anal canal there are certain glands called anal glands of Ball, and they get infected, it forms an abscess. Sometimes it forms an abscess in the ischiorectal space, which is around the anal canal, and that abscess ruptures and the pus is discharged. Now this tract which is formed from the exterior to the inside in the anal canal, that's called fistula in anum. Now, so how will you diagnose? By examining externally, we can see the external opening, but what is necessary to know is the tract, because fistulas are of two types, low fistula and high fistula, depending upon where the opening internally is going inside. The two ways of diagnosis is, one is called fistulogram, in which a small cannula is put inside this opening, a dye is injected and we look at the tract, and the other is MRI scan of the fistulous tract. So once we establish the fistulous tract, whether it is divided into two others or sub branches, then the treatment is surgery. There is no other treatment that we can think of for fistula, because infection is controlled with antibiotic and the tract has to be either laid open, which is called fistulotomy. We open up the whole tract by passing a guide wire inside, or we do a fistulectomy. We actually remove the whole fistulous tract. Sometimes after removing the fistulous tract, we also send it for biopsy looking at the tissue diagnosis, because in certain conditions like Crohn's disease, there can be multiple fistulas like this, or tuberculosis or anything, so we need to send a biopsy. So now we have understood this confusion about having a pain in the ass, which means what is the difference between piles, fissure and fistula. Now if you have understood, so what should be your responsibility? Let the other people know about it. So subscribe to my channel. Keep watching these important, informative videos and share it with your friends. And if you're having any one of these problems, that is passing blood or painful defecation, get in touch with us in Genesis Hospital, Kolkata. We will take care of you. Thank you very much for watching.